Good morning, everyone. Today, I'd like to welcome you to our event this morning. I'm Michelle Smith, Research Practice Lead for Research Quality and Knowledge Mobilization in the Research Department of Interior Health. And I'm co-moderating today co-moderating with Paula Morrison. And I'd like to share the screen or move to Paula Morrison to provide us with the land acknowledgement.
Good morning. Thank you, Michelle. My name is Paula Morrison. I'm grateful to be with you. I work as a research coordinator with Interior Health in the research department. And like Michelle, I'm focused on improving quality of life with residents and care teams in long-term care and for seniors in the community. I'm of Tahltan and Irish descent. I hail from the north, but I have been fortunate to live in the Okanagan for many years. I might divulge my age if I tell you how long. I work and play near Okanagan Lake on the traditional ancestral and unceded territory of the Silks people. Interior Health serves 7 nations in this region. I'm working on learning to say all the names, but I won't go there yet. I'm working on it. That's my New Year's resolution. One of them for professional. I invite you to share the names of the traditional and ancestral Indigenous lands that you are gathered on today. If you don't know the names of the lands of the people that you're currently joining from, please visit the website native-land.ca. And I just want to say Madu, which means thank you in Tahltan. We appreciate our presenters today for joining us and appreciate you all learning with us. I'm going to hand back to Michelle for facilitating. Thank you, Madu.
Thank you, Paula. Welcome to the 11th annual Okanagan Embrace Aging Month, and thank you for joining us today. Embrace Aging is co-hosted by the Institute for Healthy Living and Chronic Disease Prevention at UBC Okanagan, Interior Savings, and Interior Health. UBC Okanagan has joined the global network of age-friendly universities, formalizing its pledge to make UBCO more accessible, intergenerational, and committed to research programs that are informed by the needs of an aging society. If you would like to know more about the Age-Friendly University Initiative, have questions, suggestions for us, or would like to get involved, please contact the Aging in Place Research Cluster. The website is aginginplace.ok.ubc.ca, and Chiquetta as always helps us by putting it in the chat. Embrace Aging Month was launched 11 years ago to celebrate and raise awareness about positive aging, and has once again organized a number of educational opportunities and events during the month of March. The sessions are designed for everyone, young and old alike, and focus on a variety of topics related to healthy aging and ways to improve quality of life among seniors and their family caregivers. Our goal is to inspire everyone to embrace aging. We have closed caption boxes. If you like to move it to a preferred place, you can, or turn it off. You can click it off and hide it, or you can move it around in the screen. Please type questions or comments for the speakers in the chat box during the presentation, and we will read the questions out at the end of the presentation. Today's event is brought to you with support of Embrace Aging Month. Today's session is Nav-CARE, a volunteer-based compassionate community program, and our speakers are Dr. Barb, Professor, School of Nursing, co-founder and director for the Nav-CARE project, UBC Okanagan, and Dr. Kelly Ashford, the project manager for EU Navigate project, the European branch of Nav-CARE, UBC Okanagan. And now I'd like to welcome our speakers. Thank you very much and I will mute myself.
Good. Well, thank you so much for having us. We're delighted to be here today and to be part of Embrace Aging. We find this just a wonderful opportunity. I'm sorry Gloria is not here today. Originally, Gloria was going to present. She's not feeling well, but I must say, between Gloria and Kelly, they really are the magic of this program. They are project managers, both for the Canadian scale out and for the European Union scale out. And I'm so grateful to both of them. So I just wanted to acknowledge Gloria today. I'm going to start talking about really Canada or Nav-CARE in the context of Canada, and then Kelly will move on to talking about what's happening in Europe with Nav-CARE. So we always like to begin with a bit of a story, because I think it helps to illustrate what it is we're trying to accomplish within Nav-CARE. So Jim was a man in his late 70s. He was living independently at home. Not only was he living independently, but he was the caregiver of his wife with dementia. And she'd been living with dementia for many, many years, but they were doing very well at home. Then one day, Jim was outside shoveling snow and fell down and broke his hip. So, of course, Jim needed to be hospitalized to have his hip repaired. His wife needed to be hospitalized as well because, of course, he was her primary caregiver. And his surgery went successfully. He returned home. Sadly, she did not. The transition into hospital was too much for her. And so Jim came home recovering from a surgery, having reduced mobility, really having lost the love of his life and his primary purpose in life. And this was when I first met Jim. And I'll never forget coming to Jim's door for the first time. He came with a walker. He wasn't navigating that walker very well because it didn't work very well within his house. He had tears streaming down his face. He was clearly not eating very well. He had lost a lot of weight. And you could tell that even the disheveled state of his clothing, he was just having difficulty managing the day to day. And for those of you that have worked with older persons in this situation, you know that they're really at a pivotal time. They're either going to be able to adjust to this new reality, and that will take a lot of, sort of help and support, or they're going to really, so many of our older persons follow their loved ones on the trajectory of death very quickly. So Nav-CARE was really designed to make that difference. Nav-CARE stands for navigation, connecting, advocating, resourcing, and engaging. And what we do in the Nav-CARE program is we provide specially trained, mentored, and experienced volunteers to work with persons living with declining health and their families in the home to improve their quality of life. So really, Nav-CARE, it's been in process for well over a decade now, and it really has four sort of primary principles based upon some of the policy directions for palliative care in Canada. And the first really important principle is we're trying to provide early support. So you may have heard about a palliative approach to care, where we're really trying to get people upstream as soon as their declining health starts to influence their quality of life. Now, we don't use the palliative word too much in Nav-CARE, simply because we find that people still misunderstand this idea of palliative. They think it's really end of life, and the goal in Nav-CARE is really to start to contact populations as soon as they're starting to feel some effects from their illness or their declining health. The second principle is really building volunteer capacity. We have this amazing tradition of volunteering within Canada, particularly strong hospice volunteering initiative. And so we're trying to build upon that by giving an expanded scope to the volunteer and really opening up new avenues of volunteering. The third principle is really optimizing available resources. Nav-CARE was created really from some ethnographic studies that we did many years ago in rural palliative care. And one thing that we found is that there were actually a lot of resources available in rural communities that nobody knew about. And a common mantra that we would hear in these studies was, I wish I knew then what I know now about what was available to my loved one during the palliative phase. And so it's really trying to make that connection to getting people connected to their resources early. And fourth, it's all about building social connection and capital. For those of you that have been following the evolution of palliative care or support for older persons over the last couple of decades, you know that the compassionate community movement has been a huge movement in terms of trying to build bottom-up resources to caring for people in community. And so those are the four principles. So how was Nav-CARE developed? I'm not going to go into this in terms of a whole lot of detail. I would encourage you to follow that link where we have a cool little sort of video that talks about how our story and how it was developed. The main points of these slides is really that it has been well developed through research over a number of years. It started out with really a trial of a nurse navigator and really sketching out what that nurse did. then deciding, which of that role could a volunteer reasonably do, then some knowledge translation studies in terms of how is this model going to work out over various contexts? What might the problems be, the good things be? And then really scaling out to build evidence. And 2020, we received some money from Health Canada to scale it out, and we'll talk a little bit more about that in a minute. So who really does Nav-CARE serve? The primary population are older persons facing loss and declining health. And generally what happens for this population is they're often experiencing complex treatments that require really very complex decisions. Many of them may be feeling lonely or socially isolated. Nav-CARE volunteers are ideal for people who don't have a lot of family around. They could be living in urban, rural, or remote locations. Nav-CARE was a rural center model to begin with, but we certainly have had a number of implementations now within urban and remote locations. And the clientele for Nav-CARE, they could be living at home, they could be living in long-term care or assisted living. The main point is that they're in home-like situations. Who are these Nav-CARE volunteers? Well, they tend to be experienced volunteers. We do ask that they have some experience before they take the Nav-CARE training. The ideal experience is hospice palliative care training, which is, I think, 30 to 60 hours, depending on where you are. They tend to be older volunteers. 87% tend to be female, although we're working very hard to recruit more male volunteers, because as our clients go, we tend to get about 50-50. And 38% have really more than 5 years of volunteer experience, and 40% have usually some sort of healthcare background. They are supported by a coordinator within their community, and then the coordinators are supported by the Nav-CARE team. So Kelly and Gloria run a community of practice for the Nav-CARE coordinators where they connect with other persons across the country. So how are these volunteers prepared? We do have competency-based navigation education. It's available online in both English and French. We also have manuals to support in organization training, but basically the volunteers learn how to address quality of life concerns. They learn how to better advocate for persons and their families. They learn how to figure out what's in community available to them and then to facilitate those connections. How to support people living with declining health to stay engaged. So what's important to them? What do they need to stay engaged with? What do they want to stay engaged with, and how can I facilitate that? And supporting virtual navigation. So as you know, COVID-19 required a lot of virtual navigation. I mean, our whole world is supporting virtual navigation. So volunteers really learn how to support persons living with declining health to use the internet in a way, and other modes of staying connected in a way that works for them. We also have a 6th module coming on board, which is supporting persons and their family living with dementia. So what is it that they actually do? They visit in the home every 1 to 2 weeks. Most importantly, they develop relationships. So they really take that time to spend time with people, because unlike some of our other social connector models, Nav-CARE volunteers stay involved with their clients indefinitely. So that could be months to years, depending on how the relationship is going and how the declining health is going. But this is a long-term model. So as you can imagine, the most important thing in a long-term model is really that time of developing relationship and getting to know that person. They will assist with tasks that person with declining health are finding difficult to navigate, but it's usually not doing the task itself unless they're small tasks. But what their job is to help them find the resources and local services that may be formal services or informal services to help them meet their daily needs. So it might be mobilizing a neighbor, it might be finding Meals on Wheels or home delivery services. They listen to persons as they make the transitions and decisions that arise out of declining health. And really importantly, they provide a social safety net for those living at home and without family nearby. So they very much stay in touch with them. Over numerous studies, which we've mapped impact, we find that clients really do benefit from the services. They've shown statistically significant improvements in awareness of their available services, confidence in their making decisions, taking care of their illness, and communicating their needs to healthcare providers. Participants rate the service as important to their care, and most importantly, over multiple qualitative interviews, hundreds of qualitative interviews, they really are able to articulate how having a volunteer improves very practically the quality of their life. Volunteers generally have good self-perceived efficacy in their role, good satisfaction, particularly if they get connected to a client early. And most importantly, I think the volunteers benefit from this relationship as much as the clients do. So it's very much a reciprocal relationship. It's not where one benefits and the volunteer doesn't. It really develops into that special relationship that we hear a lot about with hospice volunteers. I'll talk a little bit more about stakeholders in a minute. I just want to share just some qualitative comments that really typify what we hear from clients. One client said, you know, I just find her such a caring person. I don't know how to explain it better than that. She makes me feel better just being around. It's nice to talk to someone about current events or just about the silly things that have happened to us. She's really become a friend. Another client said, I chose to have a navigator for one reason, really. I needed an advocate, and I'd used a friend, but it was just way too much. My friend works very hard, has children, and so it was too much for her. I needed to find someone who could advocate on my behalf. Another client said, I've learned to deal with some things and to accept more help. She connected me to a program in the community that now comes out to help me with cleaning. She also helped me to find low-income housing, and I didn't even know such things existed. Another client said, she helps me get out with my goals for the week. She gets my appointments and gets me involved in exercise programs. She tries to connect me to the community. And so those are very, very typical of the types of qualitative feedback we'll get from clients who've been involved in the program. I'm going to just talk for a minute about some of our learnings to date from an organizational perspective, because we only implement through organizations at this point. And then we study some of the factors that influence their implementation. And so the number one most important is organizational capacity. Does the organization have a good reputation in the community? Do they have a solid funding model? And do they have a good volunteer pool out of which to generate these Nav-CARE volunteers? Equally important is the leadership within that organization. We've really learned over time that the stability of the leadership, and probably even more importantly, a champion who really understands what the program is trying to do and has seen the need for it over time. It's really, as you know, in all of the areas of community implementation, it's our champions that move mountains. And without them, really, we just can't do it. Equally important is the messaging. Really, because it's a new program and many, many people won't understand what it is that the program is trying to do in community, really some clarity around the value added nature of the program. We have learned to avoid hospice palliative language until we get to that point in our society where people that understand palliative care is really upstream. And targeted strategies for isolated populations. So as you can imagine, some of our populations are just very difficult to reach, and yet they are the ones that we want to reach. And so we work very hard to do that. And who might that client population be? They need to be a population in need. In urban areas, we generally find that it's really important not to overlap with a population that's already receiving those services. And in rural communities, we really find that it's important to have a population where the complexity is appropriate to the volunteer role. If you've spent any time in rural Canada, you know that we often have very few services, no social workers, limited home and community care. So it's really important in those environments not to use a volunteer to fill those what should be healthcare provider roles. So that's a bit of the tricky thing in terms of implementation. Current implementation, we have a wonderful Health Canada contribution. Thank you, Health Canada, to scale out Nav-CARE across Canada using a Centers of Excellence model where we build capacity in the Centers of Excellence and then they reach out to support smaller community organizations around them. Over the last couple of years, they've done amazing work. They've trained 435 volunteers who've supported 751 persons and family. And more importantly, you know, when you're doing a new program, the piece that you really need to pay attention to is public education. And these wonderful centers of excellence and their satellite sites over the last 2 years have done 417 presentations to do community awareness raising. So honestly, they're an amazing group to work with. I often stand in awe of them. Here's sort of our distribution of sites across Canada. You can see we're really, even though we don't have a lot of sites and really sometimes only single sites in some provinces and territories, we are getting there. We've probably had our most infiltration through British Columbia. These are currently existing sites within BC. And so we're very, very grateful to our partners for this. And now I am going to stop sharing and I'm going to send it over to Kelly to talk about EU Navigate.
Thank you very much, Barb. I'm just going to pull up my screen. There we go. Okay. So Barb's just given you a really nice overview of what the Nav-CARE project is all about. And we're always looking to extend the reach of Nav-CARE and build upon the evidence base that we've already accumulated to date. And EU Navigate is just one of the ways we're able to do that at the present time. So EU Navigate is the European branch of Nav-CARE, and it's an interdisciplinary and intersectorial project funded by the European Union's Horizon Grant Programme. And I'm just going to spend a little bit of time telling you about it and the progress that we've made to date. So the project came about in 2021, and I'm just going to talk you through how the collaboration came about, the progress we've made to date regarding the adaptation to Nav-CARE that we've needed to make and how we've gone about implementing it. And then also I'll highlight what we envisage for the future and what findings we hope to see. So let's just start with that collaboration. So in the midst of COVID, a group of individuals coordinated by our colleagues from the University of Brussels came together to form the EU Navigate Consortium. And the consortium consists of ourselves and 11 other individuals, partners across Europe, and specifically those are Italy, Ireland, Portugal, Poland, Belgium, and the Netherlands. And they represent both academic institutions and non-profit organizations. And they came together because there was a need for, hopefully, a need for Nav-CARE over in Europe. And I'll just go into some details about exactly why the project came to fruition. So just like here, the number of people in European communities is increasing very quickly. And many of those individuals are living with some form of cancer diagnosis. We also know from research completed by the European Commission's Joint Research Centre that Europeans are disproportionately affected by cancer. So while they make up around 1/10 of the world population, around 25% of all cancer cases annually are occurring in Europe. And we also know that cancer disproportionately affects older individuals, with around 60% of new diagnoses and 73% of deaths occurring in that population. And coupled with that, cancer inequalities are a long-standing issue in the European healthcare system. And just like over here, while remarkable advances have been made in the cancer treatment and access to cancer care, often we see that people's postcodes and their backgrounds influence the type of care that they receive and have an impact on their health and well-being outcomes. So it's really important to try and start addressing some of these issues. But even if we move all of those stats to one side and just maybe think about our own experiences or what we see with people suffering with cancer around us, we know that they often cancer patients often find themselves overwhelmed, overburdened, and in need of information and support during their cancer journey. And that also applies to their caregivers as well. So our hope is that the EU Navigate project will help to address some of these barriers and empower people to really navigate their way through the complex healthcare systems, whilst providing them with some support and companionship along the way. So with that, the aims of the project are to take our very successful Nav-CARE program here and adapt it to fit the context of each country we are working with over in Europe. And in doing so, we're going to assess the implementation and effectiveness, both for the individuals that we're going to be involved in, and more widely, the impact that that's going to have on the healthcare system over there. Based on our hopefully successful findings, we're going to be able to make some recommendations for the key stakeholders over in Europe to help promote the integration of Nav-CARE throughout the cancer pathway and beyond, both in Europe and in other countries beyond that. And we'll also be looking at informing just the policy and practice of all the organisations we're working with, so they can then go and inform the wider or other organisations in their particular areas. So in order to achieve these aims, we are going to train and work with around 267 volunteers and social workers. And each of those individuals are going to work with about 2 to 3 people and their caregivers, giving rise to around 530 participants in total for this project. So hopefully our reach is going to be quite significant. The study is going to be conducted as a fast-track, pragmatic randomized control trial. And for those of you not really familiar with that design, I'll just unpick what that means. So it's often used in palliative care, and the research design compares an intervention group with a control group, with participants being randomly assigned to either group prior to the project beginning. And after the first 6 months, in this case, the control group will then receive the intervention as well. So the design has advantages for participants because all eligible participants receive the intervention, even if they're in the controlled group and have a delayed start. That's also beneficial for the research team because it helps to counter some of that reluctance for people to participate, knowing that they're going to be potentially put into a control group, because in this instance, even if they are in the control group, they're still going to receive the intervention. The fast track element refers to the fact that participants aren't on a waiting list. They're still receiving their usual care. This is just an added bonus for them. And so if they're in the control group, they're still going to receive this intervention. And then finally, the pragmatic element refers to us looking at the degree of effectiveness in a real world setting and all the confounding variables that may bring along with it, including diverse populations, varying conditions, comorbidities. So we want to look at the whole package to understand how this works in the real world context, rather than it being isolated in a very controlled clinical type setting. This approach is very beneficial because we can see it working on a day-to-day basis. And it gives us a real insight into how it works in the real world and how we can inform decision-making and policy changes in routine medical care for the development and implementation of programs like this. So how are we going to assess the effectiveness and how beneficial it is for people? Well, we're going to take a number of methods to assess the fidelity, the experiences of the individuals, and any barriers and successes or facilitators to the intervention, as well as its effectiveness. So we're going to do that by using questionnaires to assess key constructs, the key constructs of quality of life, well-being, and loneliness. We're going to use diaries with our volunteers and volunteer coordinators so we can understand how the implementation is going and the reach of the implementation. We're going to look at the recruitment and retention data for our volunteer navigators and for the people that are participating in the project. Interviews to really understand the experiences and perspectives of everybody involved. So we can use that to inform our recommendations. And then finally, the evaluation at the end with everybody, including those professionals that are going to be referring patients to the programme. And in terms of the timeline, T0 represents our first data collection point, and that happens prior to any randomization. So there's no influence on whether people know they're in the control group or the intervention group. T2 represents the point at which the control group will then begin the intervention or be part of the program. And then obviously T5 is where our evaluation will come in at the end. So thankfully, the European Commission liked our idea and we've successfully received the grant. So back in September 2022, we started to turn our attention towards adapting the Nav-CARE programme to the European context and just having a look at how it might work in each of the countries we'd be working with. So we spent a long time assessing how Nav-CARE might best serve each of the communities we would be working with and how the implementation of Nav-CARE might be different between those communities, while ensuring that we still held up the philosophy and values of Nav-CARE as well. Because of the geographical location of everybody, a lot of this occurred via Zoom, which was great, but it's always good to meet in person. So last year, back in April, we were fortunate enough to join together in Belgium for a very fun and productive week of reviewing all of the curriculum resources to make sure that they could be adapted and they fitted the context of each country appropriately, and also to give some training in Nav-CARE as well. At the very simplest level, just some of the language just didn't translate for some of the other countries, so we needed to make some adaptations there. And then other things like MAID is not applicable in some countries, and that's part of the curriculum. So we were just able to remove that element. Some of the other things were more cultural nuance. They were more culturally nuanced. So the way we might approach advanced care planning needed to be looked at in slightly different ways for each country. And we found that in one country, a volunteer model just wasn't going to work, and that was Poland. And so we looked at how we might be able to implement Nav-CARE in a different way. And so we're using a social work model in that context. We successfully completed that adaptation stage back in the summer. And we're now very much into the implementation phase, and our partners are working really hard to get the ball rolling with EU Navigate and recruiting our participants and volunteers, and evaluating the effectiveness and cost effectiveness along the way. So you can see from the slide here that our volunteer recruitment is going fairly well. In some countries better than others, and that's related to the organisations we're working with. So I talked about volunteer having a social work model for implementation. So they already had those in place and were able to move forward immediately with all of them. And Italy had a very strong foundation in volunteering, and it actually had an organisation it was connected with that had a very large participant pool. So they're finding it relatively easy to recruit all those volunteers. The other countries are doing a great job as well, but they're just working in a slightly different context. And now participant recruitment is slightly slower. We're looking at around 5 to 10% of our target at the moment. However, that is somewhat strategic as well, because we didn't want participants coming on board and having no volunteer navigators for them to work with. So we're just strategically recruiting them a little bit slower. So we've got people ready to work with them as soon as they come on board. Then if we look towards the future, we're looking at assessing the outcomes so we can help to refine the implementation of Nav-CARE and show how it works in practice. So we can recommend policy changes, we can recommend how practice might be able to be adapted to really ensure that this program can be sustainable beyond this project, because obviously that's what we want to see in the long term, that this project carries on beyond just the funding that we have for this particular element. So in terms of outcomes, we hope it mirrors what we've seen here in terms of increasing quality of life, well-being, improving one's self-efficacy, so their confidence in coping with cancer and everything that might bring, that they have an adaptive coping style to the process or the cancer journey, and that are able to take on board what's going on and really work with their navigator to improve their quality of life and their outlook on life as well. We hope to see increase in social and active engagement, and that includes taking an active role in their own management of the cancer journey pathway. That we see increases in the resources that they're accessing, and improved communication between the participants, their family members, and the professionals that they're working with. And then also for their caregivers to be seeing increases in their well-being and their quality of life as well. And coupled with this, we hope to see that translates to decreases in loneliness and decreases in the caregiver burden that we might be seeing as well. In assessing all of these variables, we'll also look to explore other independent variables that are known to affect health equity and equitable access to healthcare. And those include gender, age, their living situation, the level of social support they already have, and geographical location. And by that we mean the rural versus urban locations that we might find our participants in. Oh, sorry. No, I think that's about all from me. If you want to find out more about Nav-CARE or the EU Navigate project and how we're progressing with both, you can jump onto either of the websites there, or please feel free to drop us an email. It's just there right at the bottom. And I'll just finish by saying thank you for coming along today. And I believe we have some time for questions.
Thank you, Kelly and Barb. Yes, if anyone would like to put questions in the chat box, we can read them out and share them with the presenters. I always take a minute to think of my questions. Oh, and Jaquetta is saying, please type your questions for the speakers here in the chat. And we have two as well. So Barb talking about Canada and how it's progressed and grown over the years. And then Kelly, how we're spreading to the European Union and how that's going. It's a quite amazing project, all that is going on.
Yeah, it's fun, Michelle. And what's been really interesting for me, is you design these interventions and you have so many of them are culturally based, right? And so you think to yourself, oh, it'd be an easy adaptation to the 6 European countries. I was so naive. And I have to tell you, the days that we had in Belgium, we had like these 7 intensive days. And of course, everybody, when they went out into their working groups, went back to their original language. And so even trying to, figure out what was going on in the different countries and even understanding the social positioning, for example, of volunteers. And how in some countries, volunteers are a long established tradition, especially within hospice. You think of Ireland, for example, where volunteers have been kind of the mainstay of so much. And then in other countries where people just don't go into people's homes as volunteers, there's just such a high index of suspicion. And so, yeah, it was a real eye-opener for me. It's been an interesting process.
Wow. Paula, do you want me to read yours?
So
I'll read it for her. It's so interesting about volunteers. I'm curious is how you are attracting and recruiting navigators and how you are keeping them engaged. Is that the Canadian context? I guess the start for you.
I'll start with the Canadian, and then Kelly, if you want to talk a little bit about, we've had some conversations with our European partners about that. And it's interesting, because attracting volunteers has not been a big deal in the Canadian context, largely. And I think it's because, when you think about our tradition of hospice volunteers, those organizations have such spectacular reputations in their community. Anybody that's ever have had somebody in their family die and has been reached out to hospice and has felt that embracing, often those people want to turn around and volunteer, right? They want to give back in. So there really hasn't been a problem largely attracting volunteers, and it's mostly because of the organizations we work with. What's been a little bit more challenging has been retaining volunteers. Because if you don't connect them to clients in a fairly, seamless and quick manner, then they get discouraged, right? These are wonderful people who just want to volunteer. And so if you can't make the connection, they'll often find something else to put their energies into. So I would say recruiting clients has probably been one of the biggest challenges. And so then, a lot of these societies do engage their volunteers on an ongoing way. And they do that in multiple ways. First of all, every site that has a Nav-CARE program will have a coordinator. And that coordinator will meet individually and with a group with their volunteers on a regular basis. And so they share learnings, they share stories, they get ongoing education. And then, as I mentioned, also Gloria and Kelly run a community of practice for Nav-CARE programs across Canada. And actually, you know what? That has been really, really productive because people come together. And it's interesting, it's not really just about the Nav-CARE program, it's also about connecting all these coordinators about more generally, what have been their challenges, what have been their solutions. And so, it's been getting help from one another and getting support and learning what new programs they're implementing and how are they getting funding and where are they getting that funding from. And so that's really sort of the means of support that we've put in place. I'll pass it to you, Kelly, just to talk a bit about Europe.
Yeah, so what's been really wonderful is I've been able to take all of our learnings from the Canadian huddles that Barb was just speaking about and all of the challenges that our coordinators have seen with volunteer recruitment and client recruitment. And I've been able to share all those with the European partners we're working with. So we also have a hub huddle for the coordinators, so this community of practice, where they're able to come and share their challenges as well as their success stories as well, in terms of both volunteers and the clients that they're working with. And so I've been able to say, well, hey, over in Canada, we have done this. We've gone out into the community to older persons groups and chatted to them there so we can get some self-referrals as well as going out to professionals. And this is how we've approached the professionals that we're working with so that we can encourage that referral from them as well. So it's been really valuable to have that big knowledge base that I can take over with them. And then even what we're seeing between the 6 countries that we're working with there already, they're sharing some of their success stories with each other. And it's sparking ideas for people in each of the countries to go, oh, I'll go and try that with my particular community. So it's just that really establishing that network, I think, is the key piece.
Which grows with time, doesn't it?
Mm-hmm.
The networking and growth and relationship building. And when it comes to the smaller communities where there might not be volunteers, is that kind of where the struggle is right now? Does every small community have a hospice, or do they refer it out a bit farther? Like if it's a very small northern community, for example, would it be a larger center where the hospice association would be?
Yeah, that's such a great question. So where the sort of the paradigm case right now is in the West Kootenays. And so you have some really strong rural communities with, healthy hospices that have been around for a very long time. And then you have all these tiny little communities spread around. And so they've really started an amazing initiative in terms of calling themselves the West Kootenay, not necessarily, a big boundary. And they're really seeking to move out into all these tiny communities. So it's a strategy of maybe finding a volunteer in this tiny community, but supporting them through the larger hospice so they feel connected to something. And there's some really neat stuff being done up in Terrace as well, in terms of how they're bringing in all kinds of smaller communities. Quadra Island has got some really innovative things going on. And I'm always so impressed by these community organizations and how they have such a big impact with such a small capacity at times. You know what I mean? So anyway, it's been marvelous. They are the magic in terms of how they make it happen. And we basically learn from them.
Yeah, exactly, both ways. So they really take it on in that distance as well, connecting across. So that, and for the volunteers, is there support for them through the hospice or somewhere else? Like, or if they're traveling, like if there's someone that wants to volunteer in a smaller community and go out to people, maybe they're living at home in rural areas, they have support that way with the hospice?
Yes, we only implement Nav-CARE through an organization, and we
Right.
do that really intentionally because as you can imagine, there's a lot of boundary, a lot of difficult issues that come up with going into people's homes, particularly people with declining health. And so we find that organizations are really, really knowledgeable about what it takes to, recruit the right volunteers, mentor the volunteers in a good way, and really make sure that they're staying on track in terms of the job that they're supposed to be doing. And so really the organizations have the policies, the procedures, the processes to do that well. So if they want to have somebody in the smaller communities, they are definitely connected back to the larger organization, both for accountability and for learning and support purposes.
Yeah, I just echoed that last piece as well. The ongoing education and support is really key, and that helps to keep the volunteers motivated and they feel really valued and supported as well along the way. And so it just helps everybody with the success of how the program runs then.
And having that larger community of practice, that's big, probably, that's amazing.
Yeah, it's been really, really valuable. And I think when we speak to the coordinators, it's often by far and away the one thing that they like best about the whole program is that they feel supported, and they can share their ideas and they can ask for suggestions and help, so that they can go back and implement and improve the Nav-CARE program in each of their communities.
Wow. So much needed. Any questions in the chat?
I just see one about the North Okanagan. Vernon certainly has a Nav-CARE program, and they have some very, very exciting initiatives going on, of which Nav-CARE would be a piece of their home-focused program. And Salmon Arm actually was one of our very first Nav-CARE programs and built a great deal of capacity early on. Kelly, I don't think there's any other group in the North Okanagan.
No, I don't think so. No.
Yeah.
And if they're looking, because you have your site as well. So if there maybe someone is looking to volunteer, but they're not connected to a hospice, does your site help connect them to a hospice near them?
Yeah, for sure. Contact us and we'll make the connection for you.
Across, which is always helpful. Sometimes you can't find the resources anywhere. Can you explain dementia support, Barb?
Yeah, so we have another Embrace Aging presentation coming up. Kelly, do you remember what day it is?
Oh, look.
Okay, I'll tell you what it is while she looks it up. We recognized early on that there's sort of a unique group of dementia family caregivers that could very much be supported in the same way. So part of our Health Canada contribution, Tuesday, March 19th, that's great. Thanks, Chiquetta. So part of our Health Canada contribution was to adapt Nav-CARE for persons and family living with dementia. And so we'll use kind of the same model in terms of recognizing that it really is meant to connect people, to give them some social support. But as you can appreciate, there are some Very important considerations when you're working both with family caregivers, which we do in the Nav-CARE model, but we basically are focused on the client in a family-centric way. The new Nav-CARE adaptation is really very much focused on family caregivers and the dyad and a relational approach. But again, it's helping them to find resources. It's providing some social support. It's learning how to communicate in ways. And really, even it's connected to sort of dementia-friendly communities. How is it as volunteers that we can do that very grassroots community capacity building that creates opportunities for patients and families living with dementia or clients and families living with dementia? So stay posted. We have a doctoral student, Madison Huggins, who's done an amazing job on the adaptation, and she's going to walk through that systematically next week.
And Chiquita has it in the chat. That's excellent.
Great.
And how, with the European countries, are you building up people within all those countries as well, or are you directing it all back to the Canadian side? Do you have, are you building up, is there going to be all of you, a bunch of Kellys over in each of the regions as you build up?
Kelly, do you want to take that one or should I?
So obviously it's running as a research project at the moment. So we do have a bunch of me's, I guess, over in Europe at the moment, helping coordinate it in each of those particular countries, because we're obviously collecting all of our data along the way. But our hope is for the future, for sustainability, we'll have a group of volunteer coordinators that are going to remain in their positions and really champion the rollout of Nav-CARE across the European context, and have someone coordinating, I guess, a project manager type person, the hub huddles, a community of practice, so we can maintain that across all of the countries as well. I'm sure as it grows, it will morph slightly, and maybe it will grow so much that also each country will have their own community of practice as all of the as other organizations come on board at the moment. But as you can appreciate, we just have one organization in each country at the moment. But yeah, we'd be looking to grow that. I don't know if you want to add anything to that, Barb.
Yeah, I think it'd be really interesting to see. I agree with Kelly. You know, we've got kind of very 6 unique country contexts that is trying to build evidence at this point. And you know what that struggle is like with every new program, right? So you have an idea, you try to build the evidence, then you try and understand under what conditions it's working. And I suspect, you know, even just listening to sort of the gaps in the various countries, that it will take on quite unique characteristics, and that it will actually they'll brand themselves uniquely as well. We've already seen some of that in Italy in particular. I think they call them navigators, was not a word that worked well for them at all. I can't remember what the Italian word is, Kelly, but it will take on its own unique. And I think depending on whether it meets the need that they felt it needed originally, and of course they will have to do more work, because at this point they're focusing on a cancer population that is actually relatively frail. So they used a frailty scale where these really are people with declining health. And so, you know, their next step will be to see what about all the other populations who we know would benefit from a palliative approach to care, and what kind of changes do we need to make to have that work. And we've done that work here. They have not yet.
It'll be quite, and just sharing the learning across, being able to impact also Canada as well, what you're learning with volunteers and how it rolls out and what works and doesn't work.
Yeah, it's great.
And we have any other questions? I always have about 10 questions after it's over, because that's how my brain works. But
oh, you know what? Feel free, Michelle and Paula, if you get questions, to please contact us directly. We'd love to talk to people directly. We're always looking. We have a whole toolkit that is basically pick it up and take it, in terms of for organizations that are willing to implement or would like to implement. And Kelly and Gloria are very good at mentoring in that process. So feel free to reach out.
Okay. And Jekka always has contact too. If anyone contacts the line, she can connect people that are, and we will as well, and share more, and especially if you can share the toolkit. That's amazing for people to be able to do. So we want to thank you, Barb and Kelly, for today. So very impact where Lee says good luck and thanks. And we'd like to thank everyone else for attending today. And there's a little closing piece. We encourage you to attend our other events, especially the Nav-CARE Dementia that's on the March 19th, as well as all the events, Embrace Aging events. Please visit our website, Okanagan Embrace Aging.com for all the events and registration. We look forward to growing this event in the Okanagan and encourage anyone interested in supporting Embrace Aging in the future to please contact us. Contact information is available on the website. You'll receive an email with a link to an online evaluation form. We welcome everyone's feedback and suggestions for planning Embrace Aging events in the future. Thank you very much. That is all for this lovely Monday, and we'll be following up.
Thanks very much, everybody.
Thank you, everyone.
Bye-bye.
Bye.